Thank you very much indeed, Angelos. Can I have the first slide, please? So I'm going to sort of continue really with the opening remarks that my colleague made and deal more specifically with the end stage. When we consider depression or indeed any of the other major psychiatric disorders, the older the patient is, the more difficult they become to treat, the more chronic the condition. And very often it ends up with certainly the consequences of neuroprogression, which could be dementia in the terminal stage. So I want to really consider those aspects. Can I have the next slide, or can we do it from here? From here? Yeah. So really, continuing the opening remarks by my colleague, why is neuroprogression of interest to psychiatrists? It's certainly something which wasn't particularly interesting to psychiatrists a few years ago. This has now changed. If one looks, first of all, at the chronicity of the major psychiatric disorders, this is something which is of major practical concern, I think, to all areas of psychiatry. The morbidity and mortality associated with these major psychiatric conditions, again, opens up, I think, new areas where we have to consider treatment. Cognitive decline, this increases during aging processes, and we now know, of course, it's reflected in the neurodegenerative changes, particularly in cortical and subcortical areas. And the area I want to particularly address today is the fourth point on metabolic and neurochemical changes, which I think could suggest novel approaches to treatment. And this, again, is something which my colleague mentioned in his opening remarks. So, possible causes, I'm not going through the obvious genetic ones of Huntington's, Parkinson's, stroke, affective stroke and trauma, severe infections, acute infections and inflammation. And the fourth point is something, again, which Professor Laris mentioned in his opening remarks on inflammation. We are talking not of acute, severe, major inflammation. We're talking about chronic, low-grade inflammation, which is associated with virtually all of the major psychiatric disorders, including depression. So I'm going to restrict my remarks now to depression and consider really the more holistic aspects of it. We've heard the importance of stress. All psychiatrists are aware of the importance of stress as a trigger factor for major psychiatric disorders. We know, of course, for many, many years that stress is associated with a hyperactivity of the hypothalamic pituitary adrenal axis and the rise in cortisol, but also a decrease in thyroid activity, which is often overlooked, I think, in the early stages of major depression. Genetic components, yes, we'll hear a little bit about that later. What is very exciting, I think, and it will be covered in other areas, other symposia in this particular meeting, the abnormal microbiome. 10 years ago, no psychiatrists and indeed no neuroscientist would talk about gut bacteria playing an important part in psychiatric disorders. Now it's becoming center place. The microbiome is becoming very important in its effect on the way the brain functions in normal health and in psychopathology. And there are specific changes also in metabolic pathways, for example, the so-called tryptophan kynurenine pathway, which I'll touch on briefly later. So these metabolic disorders, why, if one considers the aging, depressed patient, why are they liable to die prematurely? Similarly with schizophrenia. Some die, of course, as a consequence of suicide, but the majority do not. They die as a consequence of heart disease, complications of diabetes, and so on and so forth. Physical, medical disorders. How is this connected with their psychiatric state? Well, this is where we come round to the importance of the metabolic syndrome, which is a cluster of conditions which include obesity, dyslipidemia, hypertension, hyperglycemia, and as a consequence of that, an increase in the probability of type 2 diabetes, which is enormously enhanced in all major psychiatric disorders, depression, schizophrenia, and so forth. And there's a bidirectional relationship between depression and the metabolic syndrome. And in recent years, there have been very large community-based studies actually showing this association. We cannot ignore it any longer from a psychiatric perspective. So we have to consider why. In fact, one of our Canadian colleagues, McIntyre, suggested that the mood disorders were metabolic syndrome type 2, and suggested here, which is shown in this diagram, the overlap between the changes both in pro-inflammatory cytokines, in insulin, neurotrophic factors, and so forth, and the most important aspect, which I'll now deal with, altered insulin sensitivity and how it helps to link in some of these metabolic changes with the sort of changes that we see in psychopathology. Here you can see some of the parameters which have been measured both in metabolic syndrome and in patients with major depression. And there is a complete overlap, again, in terms of many of the inflammatory mediators, and including things like adiponectin and so forth, and insulin. So we're talking about insulin resistance, we're talking about resistance of the glucocorticoid receptors, the feedback mechanisms and so forth, and how, in fact, these are associated both with the metabolic syndrome and with depression. And so what are the consequences to the brain of the metabolic syndrome? Well, again, for a very long time we've known that there's atrophy of the hippocampus, there's the thinning of the prefrontal cortex, which occurs in patients with major depression. You can measure blood flow through these areas, and there's a decreased blood flow, particularly to the frontal cortex. If one looks again at the consequences of some of the inflammatory cytokines affecting the pancreas, as a consequence of the inflammation of the islets, cell death occurs, which of course affects, therefore, insulin availability. Insulin also resistance occurs as a consequence of the increase in cortisol. I'll touch on this later on, and the inflammatory changes. And this affects profoundly the uptake of glucose into the brain. Cardiovascular disease, diabetes type 2, again, as I've already mentioned, increase. So how does this work out? Why is brain glucose, insulin, metabolic syndrome, how are they connected? Why is it important from the point of view of major depression? This is a very interesting hypothesis which was put forward by Peter some years ago now, the selfish brain theory of psychiatric disorders. Basically, the brain, as we've known for a very long time, it utilizes 20% of oxygen, 50% of body glucose, and yet the brain-body mass ratio is only 2 to 3%. This is why Peters calls it the selfish brain theory. The brain takes the glucose, it needs the oxygen to keep going. If it doesn't get it, there's problems. And we know that in major depressive disorder, there is impaired insulin receptor signaling, which has a major effect on the actual transport of glucose from the blood into the brain to maintain normal metabolic activity in the brain. We know that the insulin insensitivity increases with the chronicity of inflammation. We're now talking not of acute major inflammation, we're talking about chronic low-grade inflammation. One can show reduction in insulin receptors and the metabolic hypoactivity, particularly in the hippocampus, prefrontal cortex, and mediodorsal thalamus. All of this data is available and has been available now for some years. So, historically, it's very, very interesting that way back in the 18th century, Thomas Willis, who's of course a very famous neuroanatomist of that time, suggested that those suffering from stressful life events or long sorrow, which we would now call depression, were much more likely to suffer from diabetes. 18th century. Again, in the 19th century, Henry Maudsley, famous for the Maudsley Hospital in London, which is still present, observed that diabetes and what he called insanity were often co-expressed in families. And Menninger, in the 1930s, described psychogenic diabetes and the diabetic personality. The link, in other words, between metabolic dysfunction and psychiatric disorders. And we've known for a very long time depressed patients have at least a 60% higher risk of type 2 diabetes, and likewise the other way around. So possibly enhancing brain glucose in some way might be a new approach that we could use to reduce neuroprogression and the consequences of it. So, cognitive decline, yes, this is well established, between the decrease in brain glucose, particularly in the main cholinergic areas of the brain, the basal forebrain and the hippocampus, and this is associated with the memory dysfunction, which is a characteristic of many major psychiatric disorders. We know that the changes in glutamate function are also associated with the decrease both in brain and in glucose function. And one can actually show these changes by means of the deoxyglucose studies showing this hypermetabolic changes. And so, in short, what we're suggesting is that as a consequence of insulin insensitivity, of major depression and so forth, the effect of increase in cortisol, a presence of pro-inflammatory cytokines, that there are very fundamental changes in the intermediary metabolism, particularly of glucose, in the brain. And in this diagram here showing, in fact, some of the sites where both the pro-inflammatory cytokines and cortisol could detrimentally affect the actual transport of glucose into the brain and also the consequent utilization of glucose by the mitochondria. and as a consequence of that, severe metabolic dysfunction within the brain. Another important aspect to this, which I touched on in one of the first slides, is this so-called kynurenine pathway. This has become a source of major interest to many people, including Professor Hilaris and his group, over the more recent years, in patients suffering from major depression. We now know that this pathway is increased, particularly in major depression. Stress, cortisol, inflammation activate both the liver tryptophan oxygenase, which is responsible for triggering this pathway, but also indoleamine dioxinase, which is an enzyme widely occurring, including in the brain and periphery, which increases the passage of tryptophan away from the synthesis of serotonin down this so-called kynurenine pathway. I'm not going into the pathway itself in any detail. This is well described in the literature. But the point I want to make is this, that you will notice that the particular importance, I don't know if this works, of the pathway shown here is coming from tryptophan through to the 3-hydroxykynurenine and then down to this very specific neurotoxin, quinolinic acid. This is an agonist, a substrate to stimulate the glutamatergic pathway. So this is a neurotoxic pathway leading from the metabolism of tryptophan through, in fact, to the neurotoxin quinolinic acid. But under normal physiological conditions, quinolinic acid is a very important source of nicotinamide adenine dinucleotide. And NAD is an absolutely fundamental component of the metabolic machinery within the brain, of the citric acid cycle and so forth. And we now know that in the case of depression, that particular link is dysfunctional. So the production of a very, very important factor for driving brain energy metabolism is reduced as a consequence of the inflammatory load affecting the tryptophan kynurenine pathway. So this is a very important component when we're talking about neurodegeneration. We've got a whole number of neurotoxic metabolites coming out of that pathway, quinolinic acid being the most important one, and from the metabolic point of view, the decrease in nicotinamide adenine dinucleotide synthesis. Astrocytes, again, very important. The viability is compromised. Your astrocytic component in the brain decreases, and the astrocytes are very important again in removing neurotoxins, including quinolinic acid. So as a consequence of all these changes, we have a sort of a toxic mix of a decrease in energy metabolism caused by these changes which take place associated with the depression, chronic depression. So how about the links? Well, there's a whole number of links now, because these changes are found not only in major depression, but are particularly prominent in dementia, particularly in Alzheimer's disease. So all of these changes occur in a more exaggerated form in Alzheimer's disease. And here, just sort of summarizing the links between inflammation, type 2 diabetes and so forth, insulin resistance, effect on brain insulin and glucose function in the brain, leading to the neurotoxicity, decreased neuroplasticity and dementia. So can we use any of this very rapidly, because of time, to actually counteract some of these changes by means of the drugs that we have available at the present time? Now, some of these we've already, again, my colleague Professor Laris mentioned, non-steroidal anti-inflammatories, drugs like celecoxib and so forth, but there are a whole number of other drugs, approaches, where one can reduce the inflammatory load and possibly also enhance the functioning of insulin. And again, looking at coming back to the glucose story, there are a number of ways in which one can do this by, in other words, removing these blocks on glucose transport, increasing the availability of insulin, functional insulin, to therefore restore metabolic balance within the brain. Another approach has been to directly use ketones, because ketones can actually provide energy, brain energy, without going through the glucose transporter sites. So this has again been an experimental approach just recently, using ketone bodies and ketone type drugs to circumvent the lack of glucose. In summary, what I've done here is to put together sites whereby drugs such as minocyclines, the non-steroidal anti-inflammatories, the polyunsaturated fatty acids, statins, monoclonal antibodies, agmatine, again, a lot of the very, very basic clinical and basic work on agmatine was done earlier on by Professor Halaris's group. All of these, in different ways, modulate the inflammatory status in depression. If one then looks at the insulin receptor side, metformin is a drug which has been used now for many years for treating type 2 diabetes, but one of its functions is to enhance insulin, the functioning of insulin, and thereby indirectly enhance the functioning of the glucose transporter. So metformin-type drugs could, in fact, also be considered. So these are new ways in which we can reconsider how to reduce neuroprogression, particularly in patients with major disorder. Now, I'm not going into any of the details here, time doesn't permit, but there's a very rich literature now dealing with the not only anti-inflammatory effects, but also the potential antidepressant effects of some of these treatments, including drugs like minocycline. So, in conclusion, chronic low-grade inflammation, I think, should be seen not only as an important component of major depression, but also an important component of the metabolic syndrome which is associated with major depression and other major psychiatric diseases. I've not mentioned some of the key cells which are involved in the inflammatory response. The microglia are particularly important, and as indeed are the astrocytes. I've mentioned something about some of the neurotoxins which are produced as a consequence of the activation of the tryptophan-kynurenine pathway, and which seem to play a very important part both in the pathology of depression and also in the metabolic syndrome. And lastly, of course, I think we have to recenter now from the metabolic point of view on brain glucose and how possibly we can use new treatments to improve brain energy metabolism, which is a crucial part of the aging process, and particularly in the aging depressed patient, leading possibly to an increase in the incidence of dementia. So I think that the metabolic approach could